Good evening. Welcome to the Treatment Update 2008. We have just wrapped up the CROI conference here in Boston, and we have a distinguished panel here to discuss some of the treatment results coming out of the conference this year. So my name is Matt Sharp. I'm Director of Education at Test Positive Aware Network in Chicago, and I will let the panelists introduce themselves.
I'm Martin Delaney, founder of Project Inform and very recently become a free agent. Also a member of the AIDS Treatment Activist Coalition and the Fair Pricing Coalition.
My name is Paul Sachs. I'm a physician who works at Brigham and Women's Hospital in Boston, and I'm a member of the faculty at Harvard Medical School. I focus on HIV and AIDS and infectious diseases, and I've been doing so since 1990.
My name is Richard Elion. I'm the Director of Research at Whitman Walker Clinic, which is a community-based program in Washington, D.C. I'm an Associate Clinical Professor of Medicine at George Washington, and I think Marty and I are the oldest people here. I've been practicing HIV medicine for about 25 years.
Okay, so with that, we have we're offering questions from the audience or from the webcast participants. If you have questions, you can call in or email those questions. I guess the thing to start out with is just to sort of give us a brief update about the exciting news from the conference. If you can think of anything on the top of your head just to go into up to this point in time.
Well, I'd start by kind of putting it in a framework, and that is, you know, we've had some very exciting news in the last year or two. We've had real advances of 4 or 5 new drugs over the last couple of years that really changed the state of the art. And you can't do that every year. And I think this year is kind of the beginning of a you know, kind of slowing down of that pipeline. And consequently, we didn't see a whole lot of really groundbreaking new information here. More refinement, perhaps, and some longer-term updates. I suppose you guys would agree on that, or?
Yeah, I would agree that the pipeline right now is a little fallow, but on the other hand, one thing we did learn at this conference, one thing that we're learning increasingly, is that this is a viral disease that really should be treated so long as the treatments are safe, and that untreated HIV has all kinds of consequences that are not just immunodeficiency and AIDS, but also things like cardiovascular disease, malignancies, liver trouble, kidney trouble. So if I were to say what the sort of message from this conference was, it was if you have detectable virus, if you have any degree of immunodeficiency, that being on treatment is generally healthier than being off treatment.
Yeah. I think that's a really important point, because there's still, I'm always hearing from doctors around the country who talk about patients, they've got 3,000, 5,000, 10,000 viral load, and they think that's okay, you know, that they're doing fine. But I think the evidence now is that that's not okay, that there's real harm still.
And I think that the value, the immunologic improvements we see are kind of a continuous variable, that having more T cells to a point is better than having a little less. And there's probably a point that once you get to a certain level, it's okay, but I think we're still trying to understand what that is. And I think the social correlate of that is that we really need to get to the people who are not diagnosed and help them understand their situations. That the real social imperative from the meeting, I think, which helps us consolidate some of our gains, is in a way shifting back to the social focus that we had early on in the epidemic, helping people to understand how they can have better control over their lives by understanding their diagnosis and beginning medication. To me, that was the sort of take-home message of the conference.
Yeah. We did see, I think, some good updates on treatment information. For example, the 48-week data on the integrase inhibitors that were introduced last year, we now see that data has held up very well for a longer period of time. We've seen similar data on the non-nucleoside from Tibotec. So that's all good news. Those drugs that look so much more potent than in the past and so much safer continue to look that way this year.
And we also, in related to that, in a strategy that I know many people were interested in doing and just was untested, was the strategy of substituting raltegravir, the integrase inhibitor, for injectable enfuvirtide. And even though people have widely done this and with their clinician's blessing, it's just nice to see that in general it's safe. And so there was about a 30 to 35 patient group who switched in Canada, and they've had one breakthrough at this time, and it's not clear the cause of that. But I think overall people can be reassured that both clinical experience and starting to be clinical studies that substitution should be okay.
And I think the point there is that you're starting to see a re-emphasis on quality of life. That we're getting past the point that we're just looking for survival. That's a treatment that's clearly a quality of life improvement for those patients who don't have to use an injectable medication. And the number of patients who are resistant to therapies is declining. There was data presented that as well. And knowing that that number is declining while we have now the ability to use more tolerable second and third line approaches, I think the quality of life is really going to be improving for our population.
You know, one thing we did see, and often happens at these conferences, you get a small bit of information off in one corner or another, and it can sound very alarming. And one thing like that happened here at this meeting that I think would be important to address, and that was this report from the so-called DAD study, which is following side effects of treatments over the long term. It's a large observational study, and this year it made what I think a lot of us felt was a rather strange and hard to understand report claiming a large increase in the risk of heart attacks from 2 drugs in particular, but there was no biological mechanism of it. I'm wondering what you guys thought of that as clinicians.
I agree it was unanticipated, and I think it's important to emphasize a few things. First is that although the relative risk was increased in the people who were taking one of these 2 medicines, either abacavir or DDI, the absolute risk of heart attack was still very, very low. So in general, people are if they're tolerating a regimen, are better off staying on it pending further data. The other thing is that because of this report, that prompted the people who make abacavir to look in their own clinical trials database to see whether they were seeing similar sorts of alarming findings. And I was able to speak with them today, and they have not so far seen that, and they're investigating it thoroughly, and they're planning more investigations. So since this was an association, we can't say that it was directly causal, and as a result, I would say let's sit tight and wait until we get more confirmatory data.
Don't panic.
I think there's a variety of reasons why when you look at those databases, you can look at associations that are not necessarily causal, but that are linked in a temporal and a timely way. The regimens of DDI and abacavir, which were listed, might have been more related to regimens that were used later on in therapy. Patients may have had lower CD4 counts, which could have predisposed them to some of those same risk factors that we talked about as the rationale for starting therapy earlier. And I think to tease those things out is going to require some confirmation from the studies. And I think the worst thing that could happen would be, which we've made this mistake before, is to overreact to this information.
Yeah.
So just getting back to this idea of being on treatment being safer than being off, I thought it was interesting today to hear the person presenting the information from the SMART study. The SMART study, remember, turned out that it wasn't so smart to stop the medicines, and they looked at inflammatory markers in that study, and the person presenting it said, this is what we saw, people who went off treatment, their inflammatory markers shot through the roof, and he said, we don't see this in many other situations. He was really quite emphatic about that, and I think that uncontrolled virus triggers inflammation and triggers all kinds of other problems. So, yeah, people should not stop their abacavir containing regimens based on this information.
Now, you know, I did see some things about the pipeline that were interesting. I don't want to be too discouraging that it was all bad news or frightening reports. One thing that I was really kind of jazzed about were reports of the use of nanoparticles. I mean, this is a new term we haven't heard before, but these are these, you know, extremely small little particles that science has been working with, and they've been applied in the use of one new drug, it's called the 278 drug from Tibotec, a non-nucleoside, and when it, I guess, encapsulated in these nanoparticles, this drug, which is normally taken once a day orally, can be taken or will be taken as an injection either just once a month or once every other month. And this is really a whole new paradigm in how we would talk about treating HIV disease. And then, having heard that presentation, I was going through the posters and I ran into several other posters of people developing more of this with nanoparticles, with CCR5 inhibitors and even some using the nanoparticles as a treatment all by themselves. So I was really struck by that. This is really science fiction becoming science reality.
And it really kind of proves that anything with nano in it is pretty cool, right?
Yeah,
so,
yeah.
You know, even drug development.
Yeah.
But you're right, the whole idea of novel drug development
Right.
strategies is something that we've not really had much of in
Mhm.
HIV medicine, and it would be great for us to push the limits of drug delivery systems for our patients.
Well, I think our tools to understand viral activity and to understand the different components of the virus have evolved so much that I'm confident that we're going to find ways of interfacing with the virus in ways we haven't. I mean, the one discouraging thing is that, you know, and I can't get away with it because one of the people in the hallways of the posters, they were talking about denialism around vaccines. And it's been frustrating. You know, we're just not making the progress of vaccines that you'd like to see. And that's something that with all the progress we've made understanding the virus, I'm still hopeful, but certainly I'm a little discouraged by the lack of progress we've made with vaccines.
You know, what struck me about the vaccine, there was one sort of famous talk given that everybody was talking about by Ron DeRosiers, in which he really kind of said vaccines, they aren't feasible, we don't know how to make them, and everybody should start all over again.
Don't spend your money.
Right, but he did, I thought, give a very good explanation of why this disease is so difficult to develop a vaccine for, and I think it's helpful to the public to understand that this isn't, the problem with vaccines isn't because people aren't working on it, or that scientists are lazy, or the drug companies don't want one.
Or there's not enough resources.
Or there's not enough resources, yeah. It's because this is one damn difficult virus to make a vaccine for it.
Yeah. It's possible that the discovery of a vaccine will be the result of a serendipitous
Nanoparticle.
finding. Could be nanoparticles. Serendipitous finding in the laboratory. And when you look at the history of vaccine development, sometimes people just found things that worked, and no one understood why. And you know, as being a glass half full kind of person, I kind of, you know, think that may be the situation that happens in HIV vaccines.
One of the things I'm worried about, and I know Matt and I have talked about this, after the success of the drugs of the last few years, there are now so many really good drugs that you can give people that, as good as that is, it creates a problem. And the problem is, how do you test and develop new drugs? And you know, at this point, in order to test a drug, you've got to give the patient, to be fair and ethical, you've got to give them all the best of what you've got. And that all of that best of what you've got is now so good that it's almost impossible to show an added benefit from something else. I mean, were you getting a sense of that too?
I was getting a sense of that. Do you have any comments about how to move forward?
How do we,
You know, I hear that, and I understand it, and there's certainly a lot of truth to it. On the other hand, while the medicines we have are great, they're not perfect. And let's take a look at the most popular initial regimen, which is tenofovir, emtricitabine, and efavirenz all together as a tripla. Well, as good as efavirenz is, no one could say it's perfect. It can cause CNS toxicity, you know, makes people sleep funny, and they're groggy the first few days. The tenofovir, it can't give it to women of childbearing potential who might become pregnant. There are all kinds of ways that we can improve on it, and I'm hopeful that at least in that area, in the initial therapy area, there's going to be continued efforts.
I think it's going to stimulate us also to have ways of evaluating the test. I mean, the
Well, that's
drugs,
it, exactly.
because in salvage in second and third line regimens, where the baseline now should be 70–80% success, it's hard. You've got to have a lot of patients to show a significant difference.
Yeah.
And I think that's going to challenge both the regulatory agencies as well as the research institutions to come up with slightly different models. And I think it's going to be a moving target. It's going to be harder to do, but I think that as long as we're, you know, let's also remember that when we see these numbers, we're still seeing at least 20–30% failure rates. And, you know, statistics are people with the tears wiped off. So, I mean, that's still people we need to treat.
Well, you know, that would bring me to the next thing I was thinking of. And there was a report from Vancouver, from British Columbia, that claimed that in their cohorts now, that with the new drugs of the last couple of years, that 90% of their patients now are successfully treated below 50 copies, and that the development of resistance has become a rare event.
Yeah, I would
which is
actually,
striking.
that's something that is, that we've observed for the last several years, and that with more sophisticated use of resistance testing and better drugs,
Mhm.
the proportion of people in treatment who actually have detectable viral loads and resistance has declined,
Yeah.
and that's a great thing. That's
Well,
really
and
wonderful.
part of the message for that, we tried to get this out last year, and it's so important, I think, to say it again this year, is that we have this capability
Yeah.
now, and that for people out there, if you've got detectable virus, this is your moment.
Yeah.
You know, you can get it under control and keep it under control for the most part. And you know, it's just not a time to sit back anymore and accept detectable viral load.
And let me add one other thing, and for anybody out there, if you've never had an HIV test but you don't think
Yeah.
you're at risk, get tested to be sure, because if God forbid you would be, it makes a whole lot of difference to know about it earlier than later. The medicines are so much safer. I know in Washington, D.C., all of our initiatives these days, because we have such a high incidence rate in 25 to 45, 5% of our men and women between that age are HIV positive. We're putting all our efforts to getting people tested.
Mhm.
And we want that to be something that offers opportunities, not something that's oppressive.
Another advantage of finding out one's status and getting on treatment is one that we don't talk about enough, and that's reduction in the risk of transmission to others.
Very good.
And you know, the Swiss recently have made some news. The Swiss are by nature very conservative people, I gather, but they weren't conservative about this. They came right out and said, you know, a person who's on therapy, who has an undetectable viral load and does not have a concurrent sexually transmitted infection, that person cannot transmit HIV to another person. It was really a bold statement. I think it reflects some biology that's real, and it is very risky to say cannot, and I
Right.
think that we in the United States are maybe a little too much, but we would all agree that the risk is dramatically reduced. And one could imagine getting rid of the new transmissions through appropriate treatment.
Sure, it'll certainly help. It's that Swiss guidelines that set off a real firestorm in the U.S. and the prevention community.
Yes.
There's a lot of folks who aren't quite ready to go there.
It's a strong public health message, I think, that people have to adjust to.
Sure.
I want to just get back to the CCR5 antagonist and just a question of somebody who's in a salvage situation or that doesn't have many options. How do they make the choice and selection between, and based on what happened here in Boston, between a integrase inhibitor, say, and a CCR5 antagonist?
I could take that. Well, I think the choice is I would reframe the question a little bit, and I'd say, how does a patient who's maybe passed through various regimens and not succeeded choose an optimal regimen? And in order to do that, you want to outline as best what your options are. So first, a genotype or phenotype, and if it's many resistance mutations, including protease, then a phenotype's likely to be more helpful. Once you have that information at hand, and you and your physician have that, you then have some options ahead of you, which lets you know if you need to be utilizing the profile test, which is the test for the CCR5 that you would need to take. Assuming that you've got, because the key piece there, and we discussed this last night at length, is that you've got to establish a foundation of at least 2 or 3 active drugs in your next regimen to base your next regimen on. And so if you think you don't have to, if you could do that with existing proteases and integrase and perhaps the new non-nucleoside by Tibotec, then maybe you don't need to use a CCR5. But you also, the risk sometimes of knowing if those agents are going to work based on the genotype warrant making the move to get a profile. The difference is the test, you can order that test at the same time as you're doing the genotype, and it'll give you that option. There's some rationale to doing that in the earlier phase, because as T cells decline, the ability for patients to utilize the CCR5 drugs declines because the receptor population declines. So I think that at this point we're trying to look at establishing 2 to 3 active drugs in the regimen. CCR5s are certainly up there in terms of getting the test. I think for the most part, if you don't, because of the cost of entry to some degree, people have been a little slow, but in the patients I have who are on that regimen, it's very well tolerated. So I think at that point that you're doing, you're ready to create a new regimen, that's when you look at all what your options are and then choose with your physician based on, or provider, whatever you think the best ones will work for you.
The test that measures whether a person's virus is the right kind for a CCR5 antagonist is a good test, but it's not perfect. And I would say that in someone who has low T cells or history of low T cells, the test is less likely to give us an accurate answer. So if you're on the fence about whether to use a CCR5 antagonist or not, and you think that the test might be given the wrong information, then if you have other options, it might be worth using those.
Yeah, and the reason I think for that is not just that the drug might not work for you, but that it fails to do the job of helping protect the others against resistance.
Exactly.
And you can end up then losing
Sure.
the other drugs as well. So it's a tricky use.
It's just in the area of CCR5 antagonists and the biology behind it, there was a case report at this conference that was really almost something out of science fiction. Remember that people who have the Delta 32 mutation in the CCR5 almost can't be infected with the virus. It's really remarkable. They're so protected. And a person who was HIV infected and had leukemia received a bone marrow transplant from a donor who had this Delta 32 mutation. And then after the bone marrow transplant was successful, they stopped his antiviral therapy, and he had an undetectable viral
I
load.
talked to the investigator of that study. He was at the poster, and they're now out to day 285,
Wow.
I think it was, with this person off therapy and no detectable replication of HIV, no evidence of the integrated HIV DNA. He says that maybe eventually they'll find integrated DNA, but as long as there isn't any replication going on, this person is functionally cured.
That's
but everybody's scared to death to say that word.
Yeah.
But I think that's a case we need to watch carefully.
Absolutely.
It sets the groundwork for, an obvious kind of gene therapy.
Exactly.
Yeah.
Exactly.
Speaking of, was there anything you saw exciting about immune-based therapies?
Well, as usual, I think there wasn't a lot, but there were a couple of French studies still following through on the old warhorse IL-2, which seemed to show some benefit. And I talked to them about that, but they said, no matter what we show, the other drugs, the antivirals, are so good, you're just not going to be able to make a case to license it for this purpose.
Yeah.
So I think it's a long way off.
Sure. I mean, it's remarkable that I believe it was at the Barcelona AIDS meeting in like 2002 or so. I was sitting with a group of other people, most of them much smarter than I, and they were asked a question, an open-ended question: what do you think the next great advance in HIV therapy is going to be? And half the group said immune-based therapy, and boy, was that prediction wrong, just like the results of the Super Bowl this week. So
I think it's what people would like to be. I mean, we'd all like to see a way of fighting HIV through the immune system rather than antivirals, but the truth is, it's a heck of a lot easier to fight the virus than it is to really strengthen the immune system.
Well, I think back on the panels we've been on, Marty, where we've talked about integrated therapies.
Yeah.
And our patients do want to use natural means, and I think thinking of a way to make your immune system stronger is an intuitive way to deal with the virus. And so that appeals to us. It's just a little, I think it causes us to be more open-minded to realize that those intuitive ways just haven't been successful. And the old-fashioned ways of taking a drug to disable the virus have been more successful.
Yeah, it's hard to prove the value of the the immune modulating agents. They may have that benefit, but the kind of benefit we get out of the current drugs is really big, and what you get out of immune therapy is small and subtle. Yeah.
I think we need I think in 10 years, I'm hopeful that we'll have better agents. I just don't think this current crop is.
Yeah.
I might differ a little on that. I think that the immune system is just so complicated that just even as we think we're getting a better understanding of which pathway leads to this change and which one goes to there, we don't understand the full consequences of tweaking the immune system. And as a result, our interventions don't help, and they sometimes
Part of the frustration with the vaccine research.
Exactly.
And I wonder, one of the exciting things I think from this conference, or at least one of the things that makes me excited to get up out of bed every day, is the fact that I'm still living with HIV after all these years. And so what we're talking a lot about the aging population, the aging of HIV, and there was a session in the conference around aging, which found very encouraging on one hand, and on the other hand, there are some other issues about aging and HIV, and I wonder if you could just expand upon that a little bit, some of the highlights maybe from that.
Well, unfortunately, that was the one session that I plan on watching on the webcast. So I would encourage anyone watching to know that many of the sessions are available. But I'm a research site for the MAX trial, and our group publishes a lot on aging, and and you know, as aging becomes more attractive, it gets different names. So we don't call it aging anymore. We call it senescence. I'm not sure that's a better name, but it's called a different name than aging. But I think one of the issues relates to what Paul said about inflammation, that aging in some ways represents a pro-inflammatory state. It represents a way that the body has inflammation or is not as able to handle inflammation. And HIV is also a pro-inflammatory state. And so these two can accelerate each other. And one of the things in the MAX trial that we've seen is that our patients who are well tolerating their drugs, have viral loads that are very well suppressed, are having certain parameters of aging that are aging quicker. And I think one of the challenges as we start to understand the science here is going to be to figure out how do we modulate those things? How do we do that? But I think right now we're just beginning to appreciate the role of inflammation, even in controlled HIV to some degree, that there's some degree of inflammation that continues, and how we can modulate that.
You know, I think one of the good thing about HIV and aging is that most doctors know something about aging. You know, that what we see with HIV and aging is pretty much the same things that you see in aging, period, just at an earlier age, perhaps. So it's an area where I think docs are pretty well equipped to deal with it, as long as, you know, they're you know, spending time and looking into those issues. And, you know, it's heart disease, it's diabetes, it's bone density issues. I have to say that for one of our friends who's really concentrated on that lately as his mission, but I think he's right about that. So those are the things doctors are used to dealing with in the rest of the population, and now need to bring to bear in the HIV population.
It's really it's a price well worth paying for the success, and I just think of an anecdote. When I was contacted sort of circa 1992 about a young woman with HIV, because her primary care doctor had found that she had a very abnormal cholesterol panel, and she said to me, you know, I don't even think this necessarily warrants treatment, because how long is she going to live anyway? And I said, well, you know, I understand that perspective, but on the other hand, she's healthy now, and who knows? And, you know, I'm happy to say two things. One is that she's still alive, and the second is that she had a successful bypass operation. Just that the bypass operation was successful, but she's a person with a family lipid disorder. You know, she inherited that, and it needs to be treated just as aggressively in her as it is in anyone else. So.
You know, there's one other point I wanted to get into about the drug studies that were there. I don't know if you noticed this too, but there were lots of studies, particularly in the poster sessions, of different drugs, drug X versus drug Y versus drug Z. Dozens of studies of all these things that are available, and they all pretty much concluded the same thing. You know, that X was no better or worse than Y, and X, you know, A was as good as B, and B was a little better than C, but there was no sense of strategy to any of it. It was just kind of like try everything against everything else, and it doesn't seem to get anywhere. You know, you wonder, how do you do this in a more strategic way, you know, so you can give physicians some rational guidance of what they should do with their patients.
Well, I see it a little differently in that I think what those trials are really intended to do is to compare tolerabilities. They're called efficacy trials because that's the way you sell it. But what you're really trying to show is over 48 or 96 weeks, are they tolerated in the same way? And are the various parameters that we want to measure, such as changes in lipids, changes in the way your body looks, changes how your kidney functions, those are the real things that I think we're watching. And I think there was a trial at this particular meeting, the HEAT trial, that compared the two most commonly used nucleoside regimens and showed no difference in efficacy nor a difference in long-term tolerability. On one hand, you could see that as kind of a disappointing trial that it didn't show a difference, but to me, it says to me that the two most commonly used regimens we use are both safe.
I mean, one way of looking at it is how can all of these studies be condensed or interpreted to generate meaningful guidelines for treatment? And the latest guidelines have just been revised, and they've incorporated tenofovir and FTC, as well as abacavir and lamivudine as first-line nucleosides. And that's a change because they've demoted an old friend, which is combivir, and they've also promoted ritonavir's boosted sequinavir. I mean, there are changes to the guidelines that happen on a regular basis based on these incremental advances that we see in these studies. So.
Well, though usually physicians are way ahead of the guidelines. I served on the guidelines panel for 6 years, and I've seen other folks who have as well, and it takes so long to get something through that process that by the time you finally get it out and get it published, it's behind the state of the art of what docs are doing. But not every doc, works out at that bleeding edge, you might say. Are we getting any questions out there?
Well, we have a question here that's more about prevention, but it's about microbicides, which is sort of both. So I wondered if you would comment on microbicide, the current state of microbicide research.
Unfortunately, the news hasn't been good on the microbicide front. Microbicides have, in prospective clinical trials, have either had no effect or they've unfortunately led to a suggestion of increased risk in those who receive microbicides. On the more hopeful side, right before this conference, the makers of Maraviroc, which is a CCR5 antagonist, have decided that they're going to formulate their drug into a possible microbicide. And it's the perfect candidate because most of the virus that's transmitted, in fact, pretty much all of it is R5 tropic. And it would be an ideal, very specific way of using that mechanism of action to prevent infection.
It's funny this question comes up because in the middle of this conference, I got an email from one of the better-known people working in microbicides, and it was really like this 2,000-word rant about the problems with microbicide research and how upset he was with how it's coming about. And he was pointing to the same kind of problems that exist in vaccines, I think, which was that there's one sort of group of scientists who think the way to do this is to just kind of try various things that are out there, just keep trying them and see what happens clinically, and others who argue that, no, we need to stop for a while and think through the science of this and figure out what should work and why should it be used instead of just trying things out that fail. Because what we've had is a string of failures at this point, and it's very discouraging to something that should be a really important part of AIDS research.
Well, here's a very interesting question. So here is a person who is on a successful antiviral regimen, on a good combination, has an undetectable viral load after 17 years, and they basically want to know if they added Icentris, raltegravir, would that give them an extra boost in their T cells? Personalized question.
I think that's that is a question that a lot of people, a lot of patients are asking themselves, where they've gotten a significant degree of immune restoration, but not complete restoration. And they hear these stories that raltegravir maybe gets a little deeper into the cells or does a better job with integrated viral DNA, and would it make a difference? I don't know what physicians are seeing in this regard and whether it makes sense to try that.
So I can tell you that dealing with this situation, the person who's got undetectable viral load, and yet the CD4 cell count hasn't recovered enough, is not uncommon, and it's especially common in people who've had a long time being HIV positive. The other factors that might contribute are, some people say hepatitis C, some people say age, and age is always 10 years older than I am, so that's older. But older age. But the reality is that no study of intensifying an already successful regimen has yet been proven to increase CD4 cells. So if one were to add raltegravir to the currently successful regimen, I don't know what it would do, but I don't have any reason to think.
Isn't there an ACTG study with raltegravir?
Yeah, exactly. We're currently participating in that study. People who are on successful regimens, half of them are going to continue their successful regimen, and half of them are going to add raltegravir. And the main endpoint is to see whether that sort of latent reservoir is going to be reduced. But the other thing we're certainly going to look at is CD4 responses. So we may have an answer to this, at least in some patients.
So hold on until the end of the study.
I would do that.
Yeah, when is that supposed to be done?
So the study is is accruing right now. One of the things the study requires is it requires that people have a viral load between 1 copy and 50 copies. And probably people are thinking, well, how do you know that? Well, you have to do a special viral load assay. So.
And what percentage of the patients who are undetectable are they finding have virus? Because I mean, there's been some work done before that have looked at how many get down to 3 copies. I know there was a study that looked at that. So how many people live in that 1 to 50 range?
So the
1 to 49 range.
There's no easy answer because the assay isn't really validated the way we think of in other kind of assays. But it's a significant minority.
Yeah.
So.
Well, but wait, the way you ask the question, they all do. You know, they all have 50 or below because that's what the current assay shows.
Right.
The question is, how many of them are down there between 1 and 10 maybe, or
Yes.
1 and 5?
Yeah.
Is that kind of assay going to become commercially available?
I don't know. I just, the latest assay that was just approved for clinical monitoring actually goes down to 40 copies. It's not one that's not used very often, but whether one is going to go down to that low, I'm not sure there's that much need. I mean, one of the nice things about the 50 copy cutoff is that seems to be where drugs continue to work for a long time.
Yeah.
So. But I remember the first time it was reported, one of my patients came in and asked for it the next day. He really kind of wanted that particular assay, and I can understand that.
There was a time when we thought under 400 was unbeatable.
Right.
That was
That's
fabulous.
right.
That was really, no more virus.
But I think one of the points is, though, at the current assay being less than 50, that's all the assay measures. Probably a lot of our patients are well less than 50
That's exactly
at that point. So
Yeah.
until there's a clinical utility being shown to being 3 versus 20, and the assay would be that accurate, there'd really be no commercial viability for such a test.
Well,
so I think we need to show
we
that,
need to show it,
strategy.
Yeah,
Yeah,
exactly.
right.
Exactly.
whether it results in longer durability without resistance or, or more resistance against, poor adherence, who knows?
I think where you'll see a lot of other uses of raltegravir is going to be in, there's going to be an intensification to see if by getting virus down quicker you could decrease the number of variants that will be there and then maybe have long-term stability there. I think it's going to be easier to show changes on the way down than once things are suppressed. So I think that's more where you're going to see that kind of application.
One encouraging thing for people who are living in this situation with an undetectable viral load but a less robust CD4 response is the clinical outcome for them is generally excellent. So it's not as if we're comparing people with 200 T cells and detectable virus and finding the same OI incidence as 200 T cells and undetectable.
Along those lines, I wondered, do you think we will be seeing a movement of drugs like raltegravir into use down in the naive patient population? Where, I mean, if it does all these wonderful things so quickly, wouldn't it make sense to be using it earlier in the course of the disease?
Well, I think there's going to be a coming wave of trials looking at raltegravir and other unique combinations for naive patients. I think once the 004 data they presented some 24-week data, once that, or 16-week data, when they present the 48-week data, I think you'll see, because I know those trials are already being written and some of them are enrolling. And you are going to see if getting virus down, there's no proof right now that getting virus down quicker is going to make a long-term difference. The efaviren's long-term stability data in terms of viral suppression has been great. So it's still a concept that needs to be tested, but I'm confident that concept's going to be tested.
And with that, we're done with this session. We're going to speak about metabolic issues in the next session. Thank you.
Thanks very much.
Thanks. Great job, Matt.
Thank you.
So what does that mean? When your church is full of women who have children